basically third trimester presentations. I think this is already covered. They've just looked at all pregnancies and found that thrombocytopenia is the second most common hematological problem after anemia, and 90% will have more than 1.5 lakh, but about 10% will have lower platelets. Now, if you look at all causes for thrombocytopenia, that's how it goes. The common ones are gestational thrombocytopenia and hypertensive disorders. ITP and other etiologies are rare in the overall scheme, but we are a referral center, so we tend to see a very skewed set of presentations. These have already been covered, but just to give an overview, vaginal delivery more than 30, operative delivery more than 50, anesthesia incest more than 75, and this is worldwide, not just here. And spontaneous bleeding risk goes up with less than 20,000. This is the way I tend to think, and that's why I put this. It's look at it to say, is it pregnant specific or pregnant non-specific? And is it isolated or is it with a systemic disorder? So the pregnant specific ones are gestational thrombocytopenia, preeclampsia, HELP, and AFLP. If they are isolated and pregnancy non-specific, we are thinking of ITP, but don't forget drug-induced as well as congenital. And if it's with a systemic disorder, think about more problems, that is TTP-HUS, SLE, APLA, bone marrow problems, viral infections like dengue, nutritional, somebody who has a B12 deficiency, splenic sequestration like an EHPVO. So when you see, don't look at, we are always looking at the patient as a whole. Say, is it isolated? Is it with a systemic problem? And based on pregnancy specific or non-specific. I'm going to jump over this because this is something that I would like you to have a look at. Basically, the ones in blue are ones which are pregnancy non-specific. So it can happen anytime. Whereas third trimester, there are certain problems that tend to happen. Peripartum, postpartum, some things tend to happen. So when you see thrombocytopenia in late second, third, think about gestational, preeclampsia, HELP. And if it is peripartum or postpartum, think more about DIC, peripartum infections, TTP, HUS, atypical HUS especially. Remember, the ones which are pregnancy non-specific can happen at any point in time. So enough with the theory. So what do you think? What will you do? Some quick answers. Sorry? Associated fever. There's more history that you want to know. Fever, anything more? Louder, guys. My hearing is not as well as good as it used to be. Sorry? Are they tired? Okay. You want to know their diet to see whether they are vegetarian. Okay. Awesome. Anything more? Previous platelet counts. Bingo. That's really good. Always ask, do you have any previous platelet count? Good question to ask. Anything else? Have you ever done blood test before? What was your platelet count before? Any bleeding manifestations, any drugs. So there's a whole host you want to know. Previous platelet counts, any bleeding manifestations. Is there any abdominal pain, headache, blurring? And all my OG colleagues will know why we are asking this question, because we are worried about eclampsia. Fever. Okay, we know a lot of AUFI that presents with thrombocytopenia. Medications, never forget medications. Okay, see whether they are on any medications that can cause thrombocytopenia. And clinical examination, obviously, you're going to do a full clinical examination, specifically looking for lymph nodes, splenomegaly, check their blood pressure. I remember we had this one patient who they said, oh, it's pancytopenia, we are planning marrow. And when we did a clinical examination, there was this nice large spleen. What did we do? We didn't do marrow, we did a ultrasound abdomen, turned out to be an EHPVO with the large spleen causing that pancytopenia. So don't forget basic medicine. I think that doesn't matter whether the patient is pregnant or not. Basic clinical medicine, clinical history and examination is really important. So what tests will you do? This is the patient in OPD. What's the first thing that you would ask? IP lab. Clumps, awesome. So, are there platelet clumps and are there giant platelets? That's the first question. So, let's go to this patient. Okay, this is the report. What would you worry about? It's gestational thrombocytopenia because it's only 90,000. There's no clumps, and it's the platelet on smear is 75 to 90. Why does it happen? Because of the increased relative volume and some consumption of platelets by the placenta. Now, you cannot actually differentiate ITP with from gestational thrombocytopenia because both have very similar features and they are both ruled out kind of diagnosis. So sometimes when the platelet count falls to like 50, you don't in gestational thrombocytopenia you don't see expect to see it fall below 50. If it falls below 50, then you're dealing with something else. But if it is around that region and you're delivering the patient, then you may want to give a low dose spread just to increase it before delivery, especially if you're planning spinal or LSCS. If it doesn't improve, more likely to be gestational thrombocytopenia. If it improves, you're likely dealing with ITP. Okay, how about this one? What would you worry about? Sorry? Eclampsia, right? Because there is seizure history, you think of eclampsia. Any seizure during pregnancy, third trimester, peripartum is eclampsia unless otherwise proved. It's only you start with eclampsia and then go to the other diagnosis unless they have uh, very clear indications that there is something else. Okay, so nausea, vomiting, headache, epigastric, upper quadrant pain. Our OG colleagues are very familiar with it. If you are in a peripheral center and you get called for seizures and the patient is pregnant or in peripartum, then you have to think about eclampsia. Now, there is this set of disorders which is like a spectrum, one presenting more in one way than the other, but all of them have hemolysis. Most of them have abnormal cells. Basically, they have cystocytes. Bilis can be up, platelet counts are low, and you'll have elevated liver enzymes, usually AST more than ALT, at least 2 times upper limit. Now, how do we differentiate these three? Okay, this is just a quick illustration to say what happens with eclampsia. Again, you're thinking about this, whatever be the reason, there is some placental hypoxia, sets of inflammation. So there is increase in SFLT, low PLGF leads to all the various manifestations that we are very familiar with. Proteinuria, hepatic dysfunction, hypertension, cardiomyopathy, stroke, press, eclampsias, pulmonary edema, thrombocytopenia, the whole lot. Now, when you have eclampsia, what is the first thing you do? Okay, you deliver them, but start max self as soon as they come in. So max self, hypertension control, delivery, and delivery ASAP is the treatment. How about this one? This one is postpartum. No seizures, but blood pressure is a little on the higher side. No PIH, but she comes in looking sick, really sick that you put her into ICU. 2 days later, you're expecting her to get better, but her creatinine is going up and she's still looking sick. What do you worry about? Thrombocytopenia is falling. Severe preeclampsia is one thought. Yes, always think because you can have postpartum eclampsia and that can happen till when? 2 weeks, 7 days to 2 weeks max. Most common in the first 48 hours, but there are reports which go outside that spectrum. Anything else? Sepsis? Did you say sepsis? Awesome. Think about sepsis, especially if they've delivered outside and they've come. You don't know what has happened. Oftentimes, you don't get any detail. You worry sepsis, platelets are falling. Very good. DIC, sepsis with DIC, or they've had a large transfusion, massive transfusion protocol. Again, they can have DIC, so platelets can be low because of that. Sorry? CVT to be ruled out because patient has come like this, but the platelet count being low doesn't quite explain the CVT. It's more on the other side of the spectrum. But yes, yeah, we may relook at the counts and the thing later. But yes, maybe much lower in my differential. Okay, so TTP-HUS is again something that you worry about, and this is just a very simplistic cartoon on what happens with TTP-HUS. Basically, you have ADAMTS deficiency, which usually snips those uh, von Willebrand multimers into smaller bits and helps with lysis. When you don't have the ADAMTS, then you would have clots forming. So there is microangiopathic hemolytic anemia. But atypical HUS is a little more complicated than that. This is because of the complement system rather than ADAMTS deficiency itself. So this is a study where they looked to see, okay, how do we differentiate HELP, preeclampsia from TTP-HS? Because they all tend to present that way. They can have hypertension, renal failure, they will have elevated liver enzymes and low platelets. So how do we differentiate one versus the other? And these are the ROC curves. If you actually look at these ROC curves, the more left they are, the better that test is at discriminating. So what did they find? This creatinine and LDH has a much better area under curve. It's almost 99 and 90%. Okay, so just going back, what they found is to differentiate HELP syndrome versus atypical HUS in postpartum period, if you look at the hemoglobin is low, the platelets are low, creatinine and LDH, creatinine more than 1.9, LDH more than 600 is very good discriminating tests, one versus the other. So if you find creatinine high, LDH high, 48 hours down, think TTP-HUS. It's not a common diagnosis, but it's a diagnosis. If you miss, you lose the patient. So it's something that is critical for us to recognize. So creatinine and LDH, both of which are good discriminating index, HELP usually starts to improve in 72 hours. If the patient is not improving in 48 hours, it's going down, platelets are going down, creatinine is going up, LDH is going up, think about TTP-HUS, okay? So I'm focusing on how do we differentiate, because I think that's really important. We all know these things can present, but how do I differentiate one versus the other? Where do you find high blood pressure? You find it in eclampsia and HELP, but you may find it also in your TTP, HUS and AFLP. So hypertension per se doesn't help with uh, differentiating. Things that helps to differentiate are the severity of thrombocytopenia, much lower in TTP-HUS compared to preeclampsia or AFLP. Renal failure, again, a lot more common in TTP-HUS, and AFLP also will have organ dysfunction. So you'll find renal failure there also. But what you find with AFLP is this hepatic the dysfunction, the coagulopathy, and hypoglycemia that you don't see with all the others. So if you find coagulopathy along with hypoglycemia, elevated enzymes, think AFLP, even if there is MODS. If there is TTP-HUS, you're finding creatinine up, LDH up, cystocytes, platelets falling, blood pressure plus minus, and they are less common compared to preeclampsia. Okay, whereas here you don't tend to see cystocytes. If at all, it's a 0.1% or 0.5%, 1%. It doesn't go above. Okay, so you may find cystocytes here, but you're more likely to see that in these two disorders. You don't find that in AFLP. Okay, again, it's 0.5 or 1%, doesn't go up. So LDH again can be high in all both TTP-HS as well as AFLP. So coagulopathy, hypoglycemia will tell you that it's AFLP. Cystocytes, high creatinine, high LDH, severe thrombocytopenia, more likely to be TTP-HUS. Okay, now you talked about DIC. How do I differentiate DIC from these disorders? Remember, blood pressure they tend to have shock. So they tend to have a lower blood pressure or a normal blood pressure. The other thing is in TTP-HS, your PT-PTT is normal, whereas in DIC, PT-PTT will be abnormal. So if you do a coagulation profile, CTTPH, CPT-PTT is normal, but thrombocytopenia is there, think TTP-HUS. Whereas if both PT as well as your platelets are deranged, think DIC. Um, I think the rest I've already kind of explained. Yeah, so here, lab test, Adam TS13, we get it actually quite quickly now. So it's good to do that. Your LDH and your creatinine. In AFLP, remember again, here you'll find coagulopathy. So your PT will get deranged, very deranged LFTs, and here fibrinogenous deranged along with PT and APTT. Treatment obviously is very different. Delivery is the treatment for help. You need to give Plex. We give high dose steroids sometimes, but Plex is much better. And eculizumab is something that we don't have at this point in time. AFLP is basically intensive care delivery and supportive management. Max self antihypertensive disorders delivery. If it's postpartum eclampsia, it's just hypertension control and max self. Whereas here, you need to see what is inciting and make sure that you provide that support. Is it antibiotics? Is it DIC? Then need to give product support. So based on what happens there. Okay, I'll give you a minute to just look at it, just to see the differentiating factors. Okay, so are we okay there? Okay, I'm going to add a couple more into the mix. Catastrophic APLA and SLE. Okay, the reason being these are again disorders we tend to see because we are a referral center. Okay, now how do I differentiate there? Remember clinical history, clinical exam. Okay, that is the cornerstone there. Look at the patient, find, see if there are rashes, look for the DLE lesions, look for vasculitic lesions in their hands, in their legs. Really important to actually do clinical history, clinical examination. I cannot underline that more. Uh, but again, here SLE can have hypertension, right? Remember when they have a renal problem, catastrophic APLA, not much. And your renal impairment again can be there in both as well as TTP-HUS. So how do I differentiate? Really just consider that as a differential. If you don't consider it as a differential, you'll miss it because a lot of these features can overlap. You can have thrombocytopenia, you can have proteinuria, you can have renal impairment, hypertension. So you want to consider those two as a differential when you're seeing patients. So ask for the history, ask for the thrombosis history in the past, ask for fetal losses in the past, and check those antibodies because they are available here. Okay, so I'll finish with one nice picture that we saw. This is a lady whom we saw. They came at 30 weeks. She had no mucosal bleed, but she required multiple transfusions. Previous two normal deliveries, 7 and 9 years. And she had fever for 3 months. So skin lesions for 3 months, had a really low anemia. HB was 2, was transfused 10 times and given iron injections after iron injections. Platelet count was 80,000 outside. And clinical examination wise, we found that she had multiple nodes and she had the skin lesions over her face. And this is what I wanted to show you. I've never seen this before in my career. What do you think that is? Sorry? Leishmania? No, it isn't cutaneous leishmania. Sadly, it was even worse than that. It's actually a leukemia which had these carcinomatous nodules there. This is what her total count turned out to be. Had blasts, turned out to be AML. So we had to quickly deliver her and transfer her to hematology for treatment. So I'll stop with that. Any questions? I want to thank Medicine 5 for this opportunity to present what we love doing. And I hope this has helped you in some parts. Any questions? Audrey is there and thank them for this excellent presentation. Okay, otherwise we meet again next week. Thank you very much.